Welcome, everyone. Thank you for taking time from busy schedules to join us for this program, Botulinum Neurotoxin Injections for Dystonia, Considerations for the Best Results. My name is Janet Heischetter. I serve as the Executive Director for the Dystonia Medical Research Foundation, or the DMRF, and it's my pleasure to welcome you to today's program. This program is being sponsored by Ipsen Biopharmaceuticals, and I want to thank them for their support, not only of this program, but of the Foundation's other patient education programs as well. Before we get started, I have just a couple of announcements. In order to keep the background noise to a minimum, and because of the number of participants we have for this program, everyone but our speakers will be muted. But your questions are why we're here. Your questions are a huge part of this program. So please use the Q&A function or the chat function at the bottom of your Zoom screen to send us your questions, and send them when you think of them so you don't forget them. We've received a number of questions from people already, so thank you if you're one of those people who's already sent us your questions. We appreciate that. We will get to as many questions as we can in the time that we have allowed for the program. And we have a couple of questions for you, which we'll explain when we get to that part of the program. So one of the questions that we receive frequently, and today's program was no different, is this program being recorded? And I'm pleased to say it is being recorded, and anyone who registered for the program will receive a link for the program when it's ready. So if you want to watch it again, or if you know somebody who registered but who had a last minute conflict and is not able to join us live, they will be able to watch it once they get the link. I want to give a quick shout out to my colleagues, Veronica Diaz, who's providing technical support for the program, and Jessica Feely, who's helping us to manage questions. We appreciate both of their efforts with this program. So now on to the reason that we're here. Again, our topic for this program is botulinum neurotoxin injections for dystonia, considerations for the best results. This topic is of great interest to the dystonia community. In fact, we've had more people register for this program than we have for any other webinar the DMRF has supported. And fortunately for us, we have one of the world's leading experts, not only on botulinum neurotoxins, but on dystonia. Dr. Buz Jinnah is our speaker tonight. Dr. Jinnah is professor of neurology and human genetics at Emory University in Atlanta. Dr. Jinnah is the principal investigator, or the leader, of the Dystonia Coalition, which is an international clinical research collaborative effort supported by the National Institutes of Health. Dr. Jinnah received his bachelor's degree from Duke University and his medical degree and doctorate, his PhD, from the University of California in San Diego. Dr. Jinnah did his neurology training at Johns Hopkins before joining the faculty there, and then moved to Emory University, as I said, where he is now, in 2008. I'm also pleased to say that Dr. Jinnah is the co-chair of the Scientific Planning Committee for the next Dystonia International Research Symposium, which is scheduled for next June in Dublin. He's also a member of the DMRF Medical and Scientific Advisory Council, and we're grateful to him for all of those efforts. As I said, he is a global expert in dystonia and has served on the planning faculty for many meetings, scientific meetings. He does dystonia research himself. He helps to set the strategic direction of dystonia research programs. And fortunately for us, he also is a frequent speaker at patient education meetings. And we're grateful to him for all of those efforts in that regard. Again, just a quick shout out. Remember to send us your questions. We want your questions. Use the Q&A or the chat function to do that. And at this point, it's really my great pleasure to turn the program over to Dr. Jinnah, who's going to provide an overview for botulinum neurotoxins injections and how they work for dystonia. And then we're going to open it up for questions. Dr. Jinnah.
Thank you, Janet, for that generous introduction, and thanks to all of the folks at the DMRF and our sponsors for making this happen. As Janet mentioned, I have a lot of experience in this area, and I get a lot of questions from patients who come to me, sometimes from very far away, and we're hoping to be able to address some of the most common questions that we get. I have only a very brief presentation with 6 or so slides to get us started. And during that time, you can think of the questions that you want to ask and put them in the Q&A. It's not likely we're going to be able to get to all the questions, but a lot of times questions are overlapping or similar. So we'll try and merge them and address as many of the questions as we can. So with that, let me try to share my screen, and the first slide that is here. And I am going to put it in presenter mode. So this is me. My name and what we're going to address today is the treatment of dystonia in general. I like to divide this issue into 4 categories. The first being counseling. This is actually very important. A lot of our patients go for many, many years without a diagnosis, or they're told that they have something else for many years. And by the time they get to a doctor who knows what it is, they're a little suspicious that anyone knows what it is. So I like to emphasize that counseling regarding the disorder is very important. So people know that we know what it is, we know how to treat it. And there are many web resources like those on the Dystonia Medical Research Foundation's website that can be very helpful for getting more information and answering questions. So this is a very important first step. It's also related to treatment, and that is we have to explain to patients what treatment options are available and what you can expect, really. So the first treatment option, and the easiest one, is oral medications or pills. We have quite a few of these. At the same time, none of them is really a miracle drug, and many of them don't work very well, or they have side effects. So many patients try these things, but I would have to say that most are not entirely satisfied with medications, with a few exceptions. Another option that we have is surgery, which usually involves either the muscles, the nerves, or the brain. We try to reserve surgical treatments for those who fail other treatments that are easier, because of course it's a surgery and nobody wants to operate with the risk of infection and other potentially serious problems that result from that. It is a good option for those patients who fail more conservative treatments like oral medications and botulinum toxins. I would say for the vast majority of people out there with dystonia, the botulinum toxins are the go-to medicine and treatment of first choice. And the reason for that is because they work the best. They're pretty consistent, at least in experienced hands in working, and they don't have so many side effects in experienced hands. So what are these things, the botulinum toxins? You'll hear a lot of people refer to them as toxins, and that's in fact in their name. And I'm not a big fan of that word because they're not really toxins. They are actually biochemically engineered proteins that were originally conceived because of what we learned from toxins that paralyze muscles. So these engineered proteins are synthesized in the lab. They are modified and they're diluted, if you will, so that instead of causing a paralysis like some toxins do, they cause muscle relaxation. I tell people that they're basically injectable muscle relaxers. They, for the most part, stay in the muscle where they're injected. They stop muscle spasms, and they reduce pain associated with muscle spasms and other processes. So what's available in terms of these botulinum toxins today? Well, these are the 4 products available in the USA. There is Botox here, this is Dysport, this is Xeomin, this is MyoBlock. And this always leads to the question of, well, which one is the best? I use all of them, and I would say my experience is about that they are all about the same in terms of how well they work and what their side effect profile is. There are not huge differences among the products. However, having said this, I can tell you that some docs really strongly prefer one because they, for some reason, believe it works better. And by the same token, some patients really prefer one because they think it worked better for them. They might tell me that one product worked and one didn't. Now, the problem with these preferences is they're not all the same. Not all of them tell me they like one of these 4 medicines better than another. So people vary, docs vary in their preferences. So which one is the best? I would say none of them. They're all relatively equal. Now, how are they used? They have to be used by someone who's experienced in using them and has been well trained, because they have to be injected into the affected muscles. And what this means is picking the right muscles is very important, and picking the right dose for each muscle is very important. Muscles have different sizes and strengths, and so these things vary quite a bit. In general, with an experienced provider, there are very few side effects, unless you end up with the wrong muscles being treated, the dose is too high, or somehow the medication leaked out from the location where it was injected and you have what we call spread. Now, why is this important, muscle selection and dose? Well, let me just show you one example here. This is an example of neck dystonia, also called cervical dystonia or torticollis. And you will see here, this lady has various abnormal postures of her head and neck. And you'll see 82% of patients have this particular posture, 42% have this, 25% have this, and 29% have this. And these numbers add up to way more than 100% because many patients have a combination of these various problems. Every patient is not the same. Every patient is a little bit different in the nature of their head movement. And this makes it complicated because you need to know which muscles are doing that posture to treat. And this is not so easy. In fact, you have quite a few neck muscles, 26 to be exact. Here's a picture of some of them in this diagram. And you can see all of the different muscles here, all doing something slightly different. And you have to know which ones to treat for each posture. That's not the only thing you need to know. The other thing you need to know is the things that you should avoid putting your needle into, like veins, which are shown here in blue, coming down here and underneath that muscle. The red ones, which are arteries here and spreading backwards. And then nerves, which are these little yellow lines here. Of course, if you hit these things, you can run into problems like bleeding or nerve damage with irritation of the nerve. And so this is not something that every physician knows how to do. Here's another example, this time Blepharospasm and Mage syndrome. As many of you may know, dystonia can also affect the face, and patients with Blepharospasm and Mage syndrome are not all the same. Some of them have squinting and eye spasms, and you want to treat this area. Some of them have blinking, or the eyes won't open after they blink, and you want to treat this area. And some people with lower facial involvement need, of course, the lower face treated. And again, there are literally dozens of muscles here in the face, and knowing exactly which one to treat for which patient is something that has to be learned and requires a bit of skill and know-how. Okay, so what happens if you try it and they don't work? I get this question a lot, so I decided to throw it in here towards the end. And my answer to people who ask me this is it kind of depends how many times you tried it. So if you tried it once, I would say that customizing the dose pattern is needed. So you should expect maybe 2 or 3 tries to get it right, because the doctor has to learn from the first round of injections and maybe increase or decrease the dose, maybe add or subtract muscles, depending on the response that you get with the first round of therapy. So very, very few patients will make it work on the first try alone. It usually takes 2 or 3, sometimes a little bit more if the pattern is particularly complicated or unusual. Now, some patients come to me and they say something a little bit different, that the botulinum toxin didn't work, and I tried it 4 or 5 or 6 times and it just never worked. Here, my answer is a little bit different, and that is, it's probably a good idea to find an expert in the type of problem you have. Doctors in the community have very varied levels of expertise in all the many different manifestations of dystonia, and not all of them are expert in every one. Some of them are particularly good at one type, but don't have a lot of experience in another. And so sometimes you need to get another doctor who might be able to look at what was done, look at the dose pattern, make some suggestions, provide advice on what the dose pattern might look like if you tried it again. They may even want to try it for you. And then once they work out the dose pattern, they can give that to you and to your local doctor, and then that can be repeated without going back to the expert all the time. This is very important because I think this is probably one of the biggest concerns I hear. People try things 3, 4, 5 times. And then when they come to me, I discover that the dose is too low, or the wrong muscles are being treated, or patients sometimes come in with very complicated movement patterns that even for me, it takes a long time to figure out what's the best way to treat it. But don't give up, because it usually works. Only a tiny fraction of patients are truly resistant, and it just simply doesn't work for. I believe that is the end of my slides, and that's just an introduction. So maybe at this point, we can go to the questions, Janet.
Thank you, Dr. Jinnah. So we have a couple of questions that we would like to ask everybody first. So Veronica, can you put the polling up? We just want to take a snapshot and see. So the first question that we have for everybody is, I have tried botulinum neurotoxin treatment, yes or no? You can just click on the answer, and we'll give everybody a minute to respond, and then we'll be able to share the results with everybody online. So just click. Okay. Veronica, can you bring up the results? Okay, so almost 89% of you have tried botulinum neurotoxin treatment. Okay, that's helpful, I think. Our next question. Okay, so as Dr. Jinnah mentioned at the conclusion of toward the end of his slides, a number of patients stopped treatment, and we're curious as to how many treatments they've gone through before they stopped. So this question is, I stopped botulinum neurotoxin treatment after, and then you fill in the blank. 1 treatment, 2 treatments, 3 treatments, 4 treatments, more than 4 treatments. If you try botulinum neurotoxin and you're still on it, you don't have to answer this question. So just for those who have stopped the treatment, if you wouldn't mind sharing with us what, how many times you tried. Okay, Veronica, you wanna? Okay, so more than 4 treatments was 57%. Dr. Jinnah, does that surprise you?
Well, it's an interesting result because the 8% of people who tried it only once, and the 12% of people, for a total of 20% of people who tried it only once or twice. Be nice to know why. Is it because it just didn't work? It was too expensive, it caused side effects, etc. And is that an example of folks who just need to try more? Then for those who've tried 4 or more treatments, we don't really know if they're continuing or if they quit after that. So maybe 57% or 60% are with more than 4 treatments might be continuing to take it. And that
Right.
would suggest to us that about 40% may be kind of quitting.
Yeah, yeah. Well, we have some fantastic questions that we're going to dive into, but I thought maybe just to start us off, you see many patients and treat them with botulinum neurotoxins. What are some of the common questions that you get from your patients before they begin this treatment?
Yeah, so everybody wants to know, first of all, what are the common side effects? And my answer to them is they're really very few if this is done correctly, if the dose is not overdone and the right muscles are treated. If you give too much, you end up with too much muscle relaxation, which feels like weakness, and that can occur wherever it happens to be injected. So if it's injected into the eye region, your eyelids might get a little weak and droopy. If you inject medication into the neck region for cervical dystonia, you might get a little bit of a floppy, forward bending head. Sometimes it leaks out of the neck muscles and gets into the muscles that control your swallowing, which are right in the same area. So swallowing is another feature as well. So the main side effects are the ones that people are most concerned about, but I usually assure them that they're transient, they're uncommon in experienced hands, and if they happen, we know what to do about them.
So we've had a number of questions about side effects. Why guidance? We had a number of questions about guidance, EMG guidance or ultrasound. Is there one that's better than the other? And why do we use both in this country? I mean, shouldn't there be a prevailing sort of guidance on what we use for guidance?
Yeah, so it's a little bit controversial, the answer to that. So for example, in the face, the muscles are so characteristically located right under the skin that you don't really need any kind of guidance. Most physicians who treat blepharospasm and Mage syndrome, they don't use EMG, they don't use ultrasound, they don't use any guidance other than the anatomical maps that we know exist and control the face. So in that case, no guidance is ever needed. In the case of the hand, the situation is a little bit different. There are dozens and dozens of tiny little muscles all packed together next to each other like a bunch of spaghetti strings bound together, and you have to get the right spaghetti string. So if you don't use guidance in the hand for like a hand dystonia, abnormal posture, there's a very high probability that you won't get good outcome. And the traditional method has always been EMG, electromyography, which is a needle that actually measures the muscle activity by sound. More recent strategy has been to use ultrasound, which gives you a picture of the area and the various muscles. There are pros and cons to each one, and I don't think that either one of them is better. But for the hand, you probably need at least one of those. And then somewhere in the middle is the neck. Some doctors never use EMG for neck muscles, and they get great results. Some doctors always use EMG or ultrasound for neck muscles, and they get great results too. So it really depends on the training level of the person. If they were trained that they need to use EMG guidance for targeting neck muscles, then that's what they usually do. And they're uncomfortable stopping that. Other people are trained to identify the muscles based on the pattern of neck muscle or head movement and feeling which muscles are pulling and tense. And they feel that they don't need EMG. And because EMG is usually more painful because the needles are bigger, they say, I don't use EMG. My experience is I've done both. For the hand, I almost always use EMG guidance. For the face, I never use it. And for the neck, maybe 20% of cases, I feel like I need it. And these are cases like the big football player type guy who has a short neck and a really fat muscular area, and I can't really get my hands in there to feel what's going on. For those kinds of anatomies, I think some type of guidance can be helpful. On the other hand, sometimes you have very, very thin necks and very long necks. You can actually see the muscles sticking through the skin. you don't really need the extra work. So it's not the case that there's a simple answer, one or the other. It depends a little bit on training and what you're treating.
Yeah. How does a physician determine the dose? When you're new starting out on this, how is dosing figured, and how does the physician figure out exactly which muscles to inject and where to inject?
Yeah, so which muscles is a good question to answer first, and that relates to the pattern of abnormal movement, whether it's face or hand or neck. Looking at the pattern of abnormal movement, feeling the muscles which are tense, that's how the physician knows which muscles to treat. In terms of dose, it depends on the size of the muscle. So little muscles require a small dose and big muscles require a bigger dose. And there are actually dosing guidelines provided by all of the companies that make these medications. And those dosing guidelines usually recommend that you start on a low dose, so you don't overdo it, and then you see how it worked, and then you might increase the dose a little, and you might increase it further. But after 2 or 3, maybe 4 sessions, you end up with a relatively stable dose that you can stick with.
Oops, sorry. Is it common to inject different muscles over the course of treatment, or is it always the same muscles at every appointment?
Yeah, that's a good question. So initially, when you're tailoring the dose pattern, you might have to change things around a little bit. But after a year or two, once you have the pattern down, typically the pattern stays relatively the same over the next years, and that can be 10 years. On the other hand, a few patients do change their dystonia pattern. They may get worse. They may evolve from, say, having only upper face to including mouth. And so you have to follow the pattern. So when it moves like that, when it's a changing target, then you do have to change the dose pattern and keep up with what's new.
Yeah. So we've had a number of questions about the length of how safe it is over the course of many years. And I would add to that then, does it work less over time? So if you've received injections for 10 or 15, 20 years, are physicians having to up the dose because it's not working as effectively?
Yeah, that's a good question. So we know that there have been patients on this therapy for more than 20 years, 30, even 30 years or more, and it works perfectly fine in a lot of patients. However, as we mentioned earlier, some patients do evolve over time. Dystonia is not always a completely static event. It may change over the years, and in those cases, you might need a higher dose. So I would say some percentage of patients do need a higher dose over years. Many do not. They can stick with the same dose for many, many years. A few require less and less, and occasionally, after you've treated the problem for a few years, it goes away. Doesn't happen very often, but people aren't fixed in time with the same level of the condition forever. It may get worse, it may get better, and the doctor has to pay attention to that change and adjust the dosing accordingly.
And what do we know about the use of botulinum neurotoxin with other things like physical therapy or acupuncture? And I would add into that, are there oral medications that complement the use of botulinum neurotoxins?
Yeah, so a lot of patients try these things, many things, acupuncture, physical therapy, various herbal remedies, stretching, relaxation, yoga. Some patients find they help, and then I encourage them to continue. Some patients find they don't help, or they help only for a day or two, and they're just too much trouble to go back so frequently. So everybody's a little different. It's really hard to say that everyone has to have physical therapy or not. I think it's worth trying. And if it helps, I think it can be something that is continued. Regarding oral therapies, it would probably vary again. I would say probably at least a third of patients, maybe more, have a prescription oral medication that they keep. And either they take it regularly or they take it when they're having a bad day. And the most common ones are the benzodiazepine class of medications like clonazepam or Valium, diazepam, that kind of thing. They take the edge off the problem. They don't solve the problem. They're not a replacement for botulinum toxins, but a lot of patients like to have that prescription in their pocket in case they need it.
Yeah. And if somebody I'm not sure anybody likes shots, right? But if somebody's particularly, anxious about injections, are there things that you can do to sort of reduce that pain or, mitigate the pain at the injection site?
Yeah, that's a good thought. For patients who have facial injections, many like to put on a topical anesthetic. I would say not all of them. Some like it, some don't. I leave it up to the patient whether they want to do that. You can put it on 20, 30 minutes before your shots, and it reduces the pain a bit. It doesn't eliminate it, but it can help. For neck, where the injections are a little bit deeper, the topical anesthetics don't really work very well. So there aren't too many things that can be done to reduce the stress or pain of the injections. Some people might think, well, how about I just take a major tranquilizer and I go in and I'm, half sleepy. And well, the problem with that is that when you do that, it erases also part of the problem that the doctor needs to see so that he or she knows what to treat. So for example, in children, I often get the question, well, can't we just put them under general anesthesia and you can do the shots that way? The answer is yes, but then I'm shooting blind a little bit because I can't see the problem I'm treating. So initially I have to work out the dose pattern and then one can do anesthesia. But in general, after you work out the dose pattern, most kids and adults decide, well, okay, fine, it's not that bad. And I only have to do it every 3 months or so. So they just go through the shots. And you're right, nobody likes the shots. It would be great if we could get something that doesn't require injections. We're not there yet, but hopefully someday.
So does zinc help to prolong the duration of the botulinum neurotoxin? And I would add to that, why do people want to know why they have to have injections every 12 weeks?
Yeah, so some people have been advocating the use of oral zinc to boost the effects of the botulinum toxin and make it last longer. I would have to say that I've looked at all the studies and the results are mixed. It's not really clear that there's a big effect of zinc. Some doctors really believe in it and they really recommend it. There's no harm in it. It's just a dietary supplement, but I don't recommend it routinely to my patients because I haven't seen a big effect from it. Janet, the other thing you mentioned about duration is a big issue for many patients. So you do the injections, it takes 3 to 5 days, sometimes a week or even 2 weeks before it begins to kick in. And then the peak benefits really take 3, 4, 5, 6 weeks to reach. And then by 8 or 10 weeks, what happens is the benefits start to wane. And by 12 weeks, the average person needs to be retreated. Now, I say it that way on purpose, the average person, but as you all know, nobody's average. So some people need the treatments a little bit less than 12-week intervals. Some people can go to 14 or 16 weeks, and everybody's a little different. Unfortunately, the insurance companies have gotten on to this idea that 12 weeks is an average, and some of them have rules that prevent doctors from giving it any more frequently than the average of 12 weeks. And in those cases, I find writing a letter to the insurance company and telling the insurance company that, hey, that's an average number, and my particular patient only goes for 8 weeks. So I need you to let me treat that person a little bit more frequently than the average. And most insurance companies will agree to that. Some won't.
Yeah, that's a challenge. Insurance companies have way too much power. We battle that all the time. So, question about developing antibodies to injections. Is that still a concern that people should have?
No. Lots of people develop antibodies to these medications. but they don't seem to have any impact on whether they work or not. So you can measure antibodies, and sometimes the antibodies are really, really high, but it doesn't matter because the correlation between that and the effectiveness of the medicine is so weak that I no longer check antibodies anymore. And I encourage people not to order that test because it's not very useful.
Thank you for that. So we have a question. Somebody went from type A, botulinum neurotoxin, to a type B because they felt like they weren't getting the benefit from the A. Can they, and they didn't get benefit from B, can they go back to A?
Yes, I think that it is very reasonable if you're not having a good response and you have an experienced provider and you've really maximized the dose. I think it's reasonable to try an alternative product. As I mentioned before, some patients, at least those that come to me, often tell me they liked one product and not another. So there may be some individual variations in responsiveness to the different products. So if you were on A and you switch to B and you find out that the B is not as good, there's no reason you can't switch back to A.
And if they're not getting good results, what's your sense of, I mean, is it just not, it's just not going to work? Is it injector? Do you have a sense of sort of advice there?
So if you're not getting a good suppression of the dystonia, or you're not getting, or you're getting too many side effects, there are now 3 big studies that all say the same thing. One of the studies came from an expert center in the Netherlands. One of them came from an expert center in the United Kingdom, and the third came from our center in Atlanta. And all of us found exactly the same thing. We took a whole bunch of patients who came to our clinics and said, hey, I'm not getting a very good response. What do I do next? And we treated them. And we tried to figure out why were they not getting a good response. And in all 3 of those studies across the world, the answer was the same. The most common reason in 80% of these cases was that the dose pattern wasn't optimized for the needs of the person. Usually the dose was too low or too high, or the pattern being given wasn't quite right. And the reason this happens is because it requires a fair degree of expertise to figure out which muscles to treat and what doses to give, particularly for patients who have unusual or complicated patterns. And those are the people who often have responses that are not ideal, and they need to go to an expert center to get figured out.
Okay, thank you. Is it normal for the head to feel heavy for 2 to 3 weeks after injections for cervical dystonia?
Normal is hard to answer. I would say that that's not an effect you want. We call this head droop or head drop. The reason that's happening is because the amount of medication given into the muscles that hold up your head, which are in the back of your neck, is a little bit too high. So those muscles are getting too relaxed, and as a result, they don't hold up your head. It turns out your head is very heavy. It's like a bowling ball. And in order to keep it up on your shoulder, there's a bunch of muscles all the way around that have to be in perfect balance. So if you overtreat one of them, the head is going to droop to the opposite side. And that's what's happening there. So maybe cutting back a little bit on the dose in the, what I call the neck extensor muscles, would be an ideal solution for that. And it's a common problem. We know why it happens and we know how to fix it.
That's good.
Yes.
Resources for injecting children. I know you're an adult neurologist, but can you talk a little bit about the use of botulinum neurotoxin in pediatric patients and what resources there are to determine dose and those kinds of things?
Yeah, fortunately, there's a lot of experience with children, and it seems that children are not much different from adults, except in size. So the patterns of muscles that we typically treat in children are the same as those in adults for the same problem. It's just that the doses have to be down adjusted according to the size of the patient. So if you're talking about like a 16-year-old kid who's almost adult size, you're going to use almost adult doses. But if you're talking about a 3-year-old, you might have to adjust down the doses quite a bit. And there are guidelines for this that have been published and available widely for the doctors to use.
Okay. And a pediatric movement disorder neurologist or a pediatric physiatrist would be able to help with those issues, right?
Yes, that's exactly the case. I think expert in pediatric movement disorders or a pediatric physiatrist would be ideal because they're the ones who are specifically trained how to do this. And they're going to have dealt with some of the most difficult cases. So they're probably going to be the best to know what to do.
Yeah. We've had a number of questions about trying to find good injectors and physicians who are familiar with dystonia and experienced in providing this form of treatment. And I would just refer people to the DMRF website where we have a physician referral program, or please feel free to contact the DMRF and we'll do our best to help you get connected with an experienced physician. So that's part of why we're here. So what do we know about the use of botulinum neurotoxin in reducing pain with dystonia?
Yeah, so a lot of patients with dystonia have pain, and the botulinum toxin injections work very well for pain. Sometimes they eliminate the pain even when the movement is still there. So there's an independent effect of the medication on pain sensory nerves in the face, the neck, and other places. So we generally advise patients if they have pain that this is one of the things that should respond quite nicely.
That's great, thank you. And we had a question about whether or not you recommend dry needling along with botulinum neurotoxin. And would you just define what dry needling is for everyone?
Yeah, dry needling is somewhat similar to acupuncture, except that the therapist just puts a blunt needle into a muscle or another location that they believe is somehow triggering the problem. And in some patients, when this is done, they can have a long-lasting benefit from the dry needling. So the dry needle goes in, nothing is injected, and then it's taken out. I would say that the vast majority of patients don't do that, in part because they don't get a huge benefit from it, but some do. And for those who do, I think it's very reasonable to continue.
Great. And a couple of questions about, again, sort of long-term use. Does the neurotoxin, the botulinum neurotoxin, accumulate in the body over time? Do we know anything about that? Good
question. It seems that the botulinum toxin does not accumulate in the body over time. It has a long-lived effect of 3 months in the body, but ultimately it is degraded and eliminated. Remember, it's a protein, and your body is built from proteins, and it has a whole series of mechanisms to make new proteins, get rid of old proteins, and there's always a certain amount of protein turnover in every cell of your body. So those botulinum toxins, being proteins, ultimately fall into those mechanisms, get degraded, and get eliminated. So they don't build up over time. And if you inject it, they probably are gone within a few months, maybe even quicker, but certainly by 6 months or a year, they're gone. Okay.
Sorry, I just lost the question I was going to ask. Sorry. How effective is botulinum neurotoxin for other focal dystonias? We've talked a lot about cervical dystonia, but we've had a number of questions about some of the other focals, including foot dystonia. Do we know how effective this treatment is for those focal dystonias?
Yeah, so the botulinum toxins will work for any disorder where there's overactive muscles in any part of the body. That includes dystonia in the foot or the hand, the face, the neck, the larynx, really anywhere. You can inject it anywhere that there is dystonia, and it should work. The problem is that certain areas of the region are a little bit more challenging to treat than others. So for example, the face is very easy because the muscles are only skin deep, they're easy to access, they're small, they're very sensitive to botulinum toxin. On the other hand, the hand is more difficult That's not because botulinum toxin doesn't work. It's just because it's hard to get exactly the combination of muscles and the right dose you want because there are so many muscles. The foot is similar to the hand in that there are lots of little muscles controlling every aspect of the foot and every movement of the toe. So you have to really work at getting the dose adjusted quite right. But it should work for foot dystonia too.
Yeah. We've had a couple questions about people getting flu-like symptoms after they've had their injections. Is that a side effect of injections?
It is. So about 10% or maybe more of people who get botulinum toxins report a flu-like syndrome, which is usually very brief. Typically a day or two, it may be up to a week. They feel achy all over, not just where the muscles were injected, but all over. They feel tired. They don't typically have a cough and runny nose, but they get those other flu-like symptoms that just make them feel kind of lousy. And then a couple of days later, it's gone. And this is probably the body's response to an injection. That is, your immune system finds the proteins, it sees them, and it reacts as if the medication is some type of germ. But fortunately, these are not long-lived effects and usually go away. And sometimes this flu-like syndrome can be alleviated by switching products. And the reason for that is because each of the products has a botulinum toxin molecule, but this molecule is often mixed or combined with other proteins that help to stabilize it, for example. And sometimes the immune system is not directed to the botulinum toxin, it's directed to those other proteins. So if you switch products with different proteins, you can sometimes eliminate that problem.
Okay. And we've had a couple of questions about whether or not, or what do we know about botulinum neurotoxins collecting in the liver? Is there any evidence to show that this is a concern?
No.
No.
I don't think there's any good evidence that they accumulate in the liver or do anything in the liver. So I don't think that's something to worry about.
Okay. Okay. Thank you.
Typically, when you inject them in the muscle, they stay in the muscle. Actually, more properly, they stay in the nerve that's going to the muscle. And they don't really go too far from there.
Okay. Yeah, that's helpful. We had a question about when is it time to say that this treatment is not going to be effective, and perhaps maybe the questioner wants to know about if you fail on botulinum neurotoxin, is DBS the next treatment that they should consider?
Yeah, so if you really have an expert who knows how to use the botulinum toxins, and if you've tried it several times and you and your doctor agree that for some reason it's just not going to work, there are other options. There are surgical options. There are more than one. So for example, deep brain stimulation is one of them. It's done typically by neurosurgeons. And if you have facial dystonia, there are other procedures, for example, myectomy, sling procedures, and these are done usually by ophthalmology or oculoplastic surgeons. So, and there are other surgeries as well. So ask your doctor about them. It depends sort of what type of dystonia you have as to which one would be most appropriate.
Okay, thank you. We had a question about asking if you would address muscle atrophy over time from injections. Is that a concern?
Yeah, so whenever your muscle is activated and activated a lot, it bulks up, right? It's basically exercising by itself. And so in dystonia, we often see muscles that get too big. And when you calm down that overactive muscle activity, that muscle shrinks down to a more normal size. However, it is true that if you continue to treat it, particularly with too much, that it will keep shrinking down to a size that's smaller than usual. And when that happens, I like to back off a little bit on the dose because we don't really like to see cumulative muscle atrophy occurring, so that once you back off on the dose or stop, the muscle will come back to its original size.
Sorry, You'd think I'd have this mute thing down by now. Question about the use of heat or ice after injection. Any reason to avoid either of those if it makes the injection site feel better?
Yeah, it's a good question. One that I get a lot. I would say that most of the evidence shows that after your injections, within 5 or 10 minutes, the medication has gotten into where it needs to go. And after that, you can do whatever you want. Some doctors discourage the use of cold because they feel like it's going to slow down the activity of the botulinum toxin to get where it needs to go and do what it needs to do. I don't think there's any evidence for that. So I think if a cold pack is something that makes you feel better, maybe wait a half an hour and then use it. Hot packs are a little different. Some doctors say you shouldn't use hot packs because they might damage the protein. All proteins are affected a little bit by heat. But the amount of heat you need to damage the botulinum toxin molecule is pretty high. So I doubt anybody's using a hot pack that's so hot it would damage the protein. Nevertheless, some doctors discourage that as well. I tell people a half an hour after your injections, if you like to have a warm pack or so, it's probably not harmful.
Okay, that's helpful. We've had a couple of questions about some side effects that people, or some things that have happened to people after injections. One person reports that they have stomach trouble after receiving injections and actually some fluid retention. Any thoughts on that and advice on what they might do?
Yeah, so everybody's different and we know what the common side effects are. Every once in a while, I'll hear someone come in and tell me something that is very unusual side effect. And I usually look it up and find out that it's never been reported before. And I always wonder, is that side effect something that came from the medication, or was it just a coincidence and that there was something else going on at the time? I start to believe that it's a real side effect of the medicine when it happens over and over again. So let's say you inject the medicine and you get this stomach problem once. It could have just been a random flu. It could have been some stomach bug or something wrong you ate that day. But if you get the stomach problem every time you get your shots, then I'm more inclined to believe that for some reason, your body has developed a very unusual reaction to it. It's not common to have stomach problems or liver problems or other related problems, but everybody's different and unusual side effects sometimes happen. So I don't like to be too flat-footed and say it never occurs. I would just say that it would be unusual and I would want to see how many times it happened in a row.
Mm-hmm. Trust, for someone who has generalized dystonia and is getting botulinum neurotoxin in a couple of different areas on their body, what's the maximum dosing that they should be aware of?
Yeah, good question. So each product has guidance on what is the maximum dose that should be given. I would say that I don't pay too much attention to that guidance. I try to stay below that number. But if a patient needs more and they're not having side effects, I go above the recommended dose. And as long as they're not having side effects, I might go to double the dose that's recommended. I wouldn't recommend this be done by someone who's not expert in using it because we don't go to double the dose right away. Usually what happens is over the years, if someone comes back and says, yeah, it worked, but it was only 50% good, then I might increase the dose. And so I get to these super high doses only very slowly and reluctantly, but sometimes you need to go over what's recommended in the package insert. Is there a maximum number? I don't think so, but what I would say is at a certain dose, the number of injections being given is so unpleasant that you need to start thinking about a different type of treatment like a surgery.
And botulinum neurotoxins are being used for other conditions as well, right? In addition to cosmetic reason, right? So there needs to be someone somewhere has to be monitoring this so that
right.
Specialists are knowing what's going on, right? And that's probably the patient to be their own advocate, right?
Absolutely. So if you're not getting good results, time and time again, it's time to see if you can find someone who might have more experience. You can even ask your doctor. They shouldn't be offended if you tell them, look, it's not working. Is there someone else who you should go to? I think all doctors should be open to that idea because, we're not perfect. And sometimes we encounter things we're not experienced with. And in that case, we have to send people to someone who is more experienced. In my case, for example, I rely heavily on an otolaryngologist to inject the vocal cords inside the neck. And the reason for that is because he's better at it than I am. So I have no qualms in sending people to him when I know he can do a better job.
Yeah. We've had a couple of questions about the leftover toxin in a vial, and that can that be saved for the next treatment cycle? What happens to it? Can you address that?
Yeah, good question. So the vials come with a certain amount in it, and sometimes you don't need the whole amount, and you end up with leftover medication in the vial. I personally don't like to save the medication more than 24 hours. And some of the package inserts for the medications say that once you've made it up with liquid, that you should use it within 4 hours. So I don't think saving it for a week later or the next round is really a good idea. I know some doctors do that. They might freeze it, but I don't think it's a good idea. I always like to use the fresh material. And sometimes what I'll do is if I have a patient who comes in who needs only half a vial, I will try and schedule them on a day where there's another patient who might need half a vial. And then there's no wastage because I take out 2 different syringes and I save them for each separate patient. I label them, the vial's gone, and I use it all up. But that's not always feasible to have multiple patients in the same day who need different amounts. So I would say don't save that stuff for more than 4 hours or so, definitely not more than a day.
Okay, good advice. Is botulinum neurotoxin effective on tremors, either like a hand tremor or the no head tremor?
It is. It's reported effective for hand tremors, for head tremors, for voice tremors. I have used it a lot for these various things, and I would say it's not as good for tremor as it is for the more fixed postures like a stuck posture. But when the head is wobbling back and forth, it can help, reduces the wobble a bit, but it's not quite as good as when the posture is more stuck.
Thanks. And how effective are botulinum neurotoxin for truncal dystonias?
They are effective. They work anywhere in the bottom, in the body. Sorry, the problem with truncal dystonias is the muscles of your trunk are giant and super strong. Mm-hmm. And so the amount of medication you have to inject in them is sometimes so high that it's just not feasible to make it work. So I have a number of patients with truncal dystonia who benefit from it, but I have to admit they're the ones who end up with very high doses.
Yeah, that makes sense given the muscles. What advice do you have around the timing of botulinum neurotoxin injections and vaccinations? This has been a real concern, I think, in the last year or so. Any advice around that?
Wow, tough question. So what I tell people is the following. Ideally, you should separate your vaccinations from your toxin injections by at least 2 weeks, maybe even a month. And the reason for it is this. When you get a vaccination shot, the doctor is injecting a protein that mimics a virus. And the goal of injecting that viral-like protein is to stimulate the immune system to find it and attack it and know it and remember it for the future. So if you inject that viral protein at the same time as you inject a botulinum toxin protein, there is the risk that the immune system might get sensitized somehow to both. So there are no data on this. There's nothing to say you can't have them on the same day, but just out of caution, I tell my patients, try to separate those things by at least 2 weeks and preferably a month.
That's good advice. Thank you. Thank you. Well, we are coming up to the end of our time together. I want to thank you for the work that you do every day, Dr. Jinnah. We're so grateful to you for your clinical expertise as well as the research that you do, and for the time you've given us tonight and sharing your expertise. Answered a lot of great questions. We have a lot of questions. These questions will inform future articles in the dialogue, and we may do subsequent programming. So clearly, this has been an important topic. We did have one question that I just want to address before the end of the program, and that is whether or not our sponsors influence dystonia research, or I will say also influence this program. And I can assure everyone that none of our sponsors influence the program, that the programming that the foundation does. We select the speakers. Dr. Jinnah graciously has given us his time today. Our sponsors don't have any input into that or the content of the program, nor do they influence the direction of the foundation's research program. We're lucky to work with expert researchers like Dr. Jinnah, who help us set the direction of our research program. So please, everyone, rest assured that there's no influence by any sponsor to any of our programs. So, but thank you again. This has been just terrific. We may call upon you again to do subsequent programs, because clearly this is a really important topic for the community. So thank you very much.
Well, thank you for the invitation. I appreciate it. And I'd like to thank all the people who tuned in. I see that there are over 200, close to 200 Q&A questions and more than 99 comments in the chat. I apologize if we didn't get to everything. Maybe next time.
Yeah, no, I would as well. You know, there's just we got to figure out how we can make more time in a day. But we will get to those questions. And thank you everyone for the great questions. So you really helped to make this program. Thank you everyone. Thanks, Dr. Jinnah. Bye-bye.